brings us to the last presentation about the retained fragments. والحقيقة يعني I don't have to mention the lots of advantages of phacoemulsification over extracapsular cataract extractions and faster recovery, less surgical induced astigmatism, who mainly eliminated almost totally the risk of choroidal hemorrhage. But at the same time of this list of advantages, we have new complications that have been introduced to us by phacoemulsification, like wound burns, Argentine flag, dropped nucleus, capsular block syndrome, capsular phimosis, late in-back subluxation, and retained fragments. And today we're going to talk about this, one of this long list of newly introduced complications. What if left trained? كتير قوي من الجراحين يقول لك طب دي حته صغيره تبقى it will absorb. Actually, it will not absorb. It causes persistent uveitis, elevated intraocular pressure, corneal edema, cystoid macular edema, and they are immunologically indigestible. They just keep staying in the eye. They might get emulsified but not absorbed. وطبعا دي حته كبيره جدا انا يعني موريها دي. Sometimes we leave micro fragments behind. وبص تلاقي العيان بتاعك ده كل ما توقف له الستيرويدز يجي لك تاني بسيلز painful, photophobia very characteristic, وتديله ستيرويدز تاني تبتدي يحصل له سيستويد ماكي. انت مش فاهم ايه اللي بيحصل. Probably there are hidden micro fragments somewhere. احنا we need to give some attention to this area. وانا بقول لكم هنا الخريطه هم احنا مع الخبره واحنا lost lots of fragments. احنا طبعا we are not talking about dropped fragments. We are talking about retained fragments in what seems to be a straightforward case. احنا حفظنا الاماكن اللي بيستخبوا فيها وهم 5 اماكن. Inside viscoelastic remnants you have not washed, or under the phaco tip, under the place of the phaco tip. Number 3 inside or under the corneal wounds. Number 4, which is the most important because they are invisible, inside the ciliary sulcus. And number 5 in the angle we go through each part of them. Within the viscoelastic, actually طبعا we owe a lot to the viscoelastic in هم they protect the cornea, but at the same time they have also this advantage of holding the micro fragments inside them. احنا زمان كنا بنقول نسيب الفيسكولاستيك it will absorb, but I'm telling you you have to remove as much as you can of every bit of the viscoelastic, not because they do not absorb. Yes, they do, but actually they contain microfragments inside them. So you would wonder why these fragments are floating and sticking to the endothelium of the cornea, because actually they are not sticking to the endothelium, but they are contained by the viscoelastic. If we have a bolus of viscoelastic, definitely it will have microfragments that were shot inside the viscous bolus and staying there inside. If you go and magnify this and look at the trabecular meshwork, then with time the viscoelastic will just disappear and absorb, leaving behind بطريقة المصفى شوية microfragments that will stay there for you and cause recurrent uveitis to this patient. And they also go behind the phaco tip. We have this gush of fluid going from the sides of the sleeve that pushes the fragments into the tip. But actually this area is a dormant area where the fluid is very stagnant, and the fragments that are entrapped here, they stay stagnant. I always give you this asterisk to the expected place of the microfragments. You have to look at this place behind the phaco tip. You can often see retained fragments there. Underneath or inside the corneal wounds. Again, this is a favorite place because the corneal wounds are usually hydrated by the time of the surgery and easy to have fragments hidden there. I always like to wash and look for the microfragments or the big fragments at the area of the hydrated corneal wounds. You can see here there is a small bit of a fragment inside the main corneal wound. If you can see it, the asterisk will show right now where there is a fragment. One of the mistakes is to irrigate the corneal wound, hoping the fragment to go away. Actually, it went from the wound into the sulcus. But the right way to wash it out is to introduce the irrigation at one port and press, and to get a gush of fluid into the corneal wound to wash the fragment out. This we call hydroexpression. And now the most important part is the fragments that are hidden in the sulcus and they get invisible. Sometimes when you are enjoying the end of your straightforward, beautiful surgery and hearing the kettle boiling and preparing yourself to have a cup of tea, then when you do the hydrodissection, the stromal hydration, you can see it now at slow motion coming, and that disappeared into the sulcus, and this is in a reverse action. This big fragment has actually went and hid into the sulcus. You always ask yourself, how did that happen? Because actually it looked to me like a straightforward. This is the case where the fragment disappeared. I reviewed the surgery. The surgery looked straightforward. But here at the side of the asterisk, you see that this portion of the fragment is showing at the sulcus. How did it go into the sulcus? We'll show this surgery again in slow motion by flashback, and keep concentrating on this last bit at the tip of the phaco tip, and repeated it again in very slow motion. That I noticed that this last shot was actually, the last piece was actually shot into the sulcus. Not aspirated, but actually shot into the sulcus. احنا طبعا كلنا كنا بنحب في الاول، انا جايب البارامترز هنا. البارامترز دي now we're using much slower parameter, much lower bottle height, and we're working under much slower parameters because actually دايما في ترند كده يقول لك الجراح ده شاطر بيخلص في 10 دقايق، وده في 7 دقايق، وده في 6 دقايق. انا الحقيقه لو انا عندي كاتراكت افضل ما اروحش لاسرع جراح، اروح لادق جراح اللي هو ما بيسيبش فراجمنتس بيهايند، اللي هو بيبولش البوستيريور كبسول، اللي بيدور على الريتيند فراجمنتس، اللي بيأتند تو استجماتيزم زي دكتور احمد كان بيورينا. and these all things will take time. يعني دلوقتي انا ملاحظ ان في سبق مين اسرع جراح فينا. الحقيقه حابب انكم ما تخشوش في السبق ده. انا رايي ان كل عيان ياخد وقته وتدور على حاجات زي كده. attend to his astigmatism, attend للسب incisional cortical matter مثلا, polishing of anterior capsule, polishing of posterior capsule, making sure the lens is in perfect position. All these things take extra few seconds each step. جايز تزود لك دقيقتين 3 على اخر العمليه، ما تفرقش طالما العين هيبقى كويس. ما هو ليتر هتنه رايح جاي عليك وهيخش يمكن العمليات تاني وهياخد اكسترا تايم. بيحصل نفس الحكايه في الاي اي. اديك شايف ان في بيس كده بنحاول نجيبها، طارت ما تعرفش راحت فين. actually it went into the sulcus. فعشان كده انا رحت and irrigated the sulcus and it came back. برضو to show it in slow motion, what pushed this piece into the sulcus was the very high irrigation bottle with a very strong stream of fluid that pushed the lens into the sulcus. And when you go in and wash the sulcus, we were lucky to get this piece back. So sulcus wash really is a term. I hope that I can add it to your steps of phaco. Before you finish the surgery, you just introduce your irrigating tip. You just introduce irrigating tip into the sulcus, and so often you get small pieces you never saw where it went and when it went, coming back to your aspirating port. So sulcus wash In this case, I'll just show you a slow sulcus wash. It takes 10 seconds on each side, but it spares the patient months of suffering. Months بالإس يعني many months. Not always you get retained fragments back, but it makes you sure that the sulcus is clean. And the last advice is angle irrigation. This case looks nice at the end, but when I irrigated the angle, I could see that there is plenty of viscoelastic that I could not see and is coming out. So again, another extra 10 seconds to wash the angle by what I call it angle irrigation. You get viscoelastic, and we all know now that the viscoelastic is almost always holding pieces inside them. So it's nice to irrigate the angle either by simple irrigation before you do stromal hydration, or by your irrigating probe during IE. If you see postoperative residual fragments, this does not mean if you wait they will absorb. They will not absorb. You have to go in with a small pupil and pick them with aspiration and crush it with the irrigating instrument, or by using visco expression. You can have the piece going through the wound. This is the case we showed at the beginning of the presentation. So my take-home message is you need to be aware of this issue. Look for retained fragments before you conclude your surgery at the wounds, the viscoelastic and sulcus wash and angle irrigation. Use lower phycodynamics if possible. Do not share in the race of who finished the quickest. And thank you for your attention.